This week on the BackTable podcast.
I think the future is really going to be being able to tailor a pre, peri, and postoperative antibiotic course to a patient, understanding where they are, how their other health parameters play into it, instead of just saying, regardless of what else is going on in the patient, if this comes back, this is what we're going to do. Taking into account, are they immunocompromised? Is there a reason where, maybe they don't have as much reserve as another patient? So we should err on the more cautious side in terms of treating things. And then really, bacteria do help us. And so, again, moving the conversation away from sterilization and complete cleaning of the GU tract to restoring that balance so that everything is functioning the way that it should be.
Welcome to BackTable Urology, everyone. I'm George Koch from The Ohio State University, and I'm really excited to introduce Dr. Joshua Sterling from Yale University today to discuss antibiotic stewardship in reconstructive urology. Thanks so much for being here, Josh.
Yeah, thanks for having me. Really excited about what we're going to talk about today.
Yeah, very, very much so. You and I have had a bunch of conversations about antibiotic stewardship and, really put our heads together about some projects. So I'm very excited to go over it with you today. Could you start by telling us a little bit about yourself and your path to reconstructive urology?
Yeah, so I didn't have a very straight path to reconstructive urology. I kind of tried a bunch of other things and ended up there. My background is in engineering. Growing up, I was always a tinkerer, building stuff with my dad and things like that. And when I got to residency, the only thing I knew I didn't want to do was oncology. And then slowly kind of realized that there was this world where not everything was set, where you can kind of, for lack of a better word, play with what you're going to do for the patients and really, kind of personalize the treatment that you're giving them. And that's kind of really what sucked me in. And once I figured that and it just approach everything like it's an engineering problem and a problem set, I was hooked and there was no going back.
Yeah, no, definitely a field where you, your word, where you can tinker. So it sounds like it was a good fit. And about antibiotic stewardship, could you tell me a little bit about kind of what your interest is in antibiotic stewardship and the urinary microbiome and reconstructive urology?
Yeah, so I think I didn't pay much attention to it in training. I was just kind of, culture would pop up, you treat it. We had our standard protocol at SUNY Upstate and never really questioned it. And then probably the first year I was in practice, I got a culture for a bacteria I'd never heard of before. They started like subspeciating our different species of Klebsiella and looked into that and realized that what we think of as, bacteria and then positive urine cultures is probably the tip of the iceberg. And if there are actual, ribosomal differences and enzyme differences in the bacteria, maybe there are clinical differences as well. And so kind of really tried to dig into it and realize that there wasn't much there, at least in the urology literature, which is kind of, UA reflex to positive culture. If culture there, then treat. And, I realized that there's a wide world where we could really be doing a lot more for patients. I think that's when I started talking to people about it and getting interested and realizing that I wasn't the only one having these thoughts.
Mm-hmm. Yeah, I think a lot of us have that moment. Mine came, so I was a chief resident at Vanderbilt, and we had a couple of patients who had like urosepsis and bacteremia, and one went home needed a PIC IV antibiotics for 2 weeks. One person went home on like 5 days of Bactrim. Like, it was very different. And I remember saying, okay, well, I'll do one of our like education sessions on, urosepsis and bacteremia, so that, when these patients come in, we won't have to consult ID. We'll just take care of the bacterium ourselves. It shouldn't be that big of an issue. So I reached out to one of the infectious disease doctors, and they were like, that's not how bacteremia works. Like, it's not just like bacteria in blood, this is your antibiotic duration. And I was a little hell bent on it. I was like, I am going to figure this out. So I go and I get the ID textbook, like they're Campbell Walsh. And I find out that each bacteria, like each subspecies of bacteria in this book, has its own chapter. Like that's how they broke it down. And I was like, oh, this is not a disease process thing. This is a bacteria thing. And I am never going to, I had to like abandon the idea, because it was preposterous, I think, of me to think that we could just like, oh no, I know we get ID consults, but let me just like cover this in a lecture real quick. And it was the first time that I, similarly started thinking about, we are in a little bit of a data-free zone, and then going into recon, it was more of a data-free zone, but we deal, unlike maybe andrology and infertility, although they have implant infections or, stones and urosepsis from endoscopic procedures, I feel like every single one of my patients has a tube, and it's not like some patients who I have to make these decisions on. It's every single little patient has a tube of some form or fashion. So I think in recon, it's really the thoughts that I think you were having and that I have are like pervasive. We just maybe don't always talk about it.
And all it takes is one patient where your entire repair breaks down and you're like, what else could I have done? How could I have prevented this? And suddenly, you're spiraling. I know in medicine in general, we try to be, evidence-based and data-driven, but that personal N of one case is really hard to ignore. And so especially in an area where there is a lack of, level one evidence and just a couple of case series and small things, it really is kind of hard to break some of the habits that we pick up over time.
Yeah. And like those patients, when they happen, like you remember them and all you can think about is like, if this person wouldn't have had, pyelo after their ureteral stricture or a raging UTI or a fluid collection that got infected, maybe their urethroplasty would have healed, they like definitely stick with you.
Yeah, absolutely.
So what does antibiotic use look like in reconstructive urology? What's like the current landscape?
So I think surprisingly, the current landscape is pretty varied. Looking at it, talking to colleagues and looking at the literature, everyone knows that bacterial infections are bad and can definitely affect our repairs. And past that, there really isn't a lot. So, I think it's pretty standard across the board to get a pre-op culture regardless of what you're doing, and then treat that. But, kind of what is a symptomatic UTI comes into question for patients that are colonized. Kind of what are we doing for that comes into question. And I think the only area that is pretty clear is, okay, if there is, a greater than 100,000 colony forming units, we're going to treat that. Not everyone is going to get a proof of treatment, so a culture afterwards. I think everyone gives, 24 hours of antibiotics, and then it's a bit of the wild, wild west again afterwards. Everyone wants their patients to do well, and we kind of think of it as the downside risk of, sprinkling a little prophylactic or treatment antibiotics for a little bit while they have extra tubes in, beats having to go back to the operating room. And I think that fear and concern for patient really drives a lot of the practice. And it's very difficult to run a trial where you're like, this might hurt you, but we're going to see what happens with it.
Yeah, and it's tough you don't see the MDROs that you're forming, right? When you give someone a couple extra antibiotics and, they may never have trouble. Very few of them actually get C. diff, but you're right. It's like really hard to say, man, we just did this really tough 4-hour case for this person. They really like kind of put themselves in our hands, and I really don't want them to have a complication. Let me just give them something and then they'll have it. And then we won't have to worry about it. But there's definitely been some, I think it's Glenn Wernberg from Cleveland. When he was a resident at Cleveland Clinic, had a bunch of like biofilm research that showed that like even small doses of antibiotics like will change biofilms and will change urinary microbiomes like pretty quickly, and can cause some resistance patterns pretty quickly. So like, it makes us feel good because we feel like we're protecting our patients, but maybe we're not. We just like the horizon time of the problem is not within our, catheter pull. So we don't think about it.
And maybe, they go back to their local urologist. And so you never see it. And you're going to see the patient that does have the problem because they get the wound infection for that. I know there's a couple of good papers out of Japan where they kind of put in strict protocols for who gets antibiotics and who doesn't. And they saw actually a decrease in bacterial antibiotic resistance from it. Just kind of shit. I think it was a 25% drop in terms of Cipro-resistant common bacteria. And so, yeah, we don't think about that. We don't think about what you're doing. There's always another antibiotic until there isn't. But it is definitely something we need to be more cognizant of and really need to be thinking about as reconstructive urologists and urologists in general.
Yeah, I think that it's I think it's rare that we see the urethroplasty patient that ends up like that with, no oral options, but it's the neurogenic bladder patients and the SP2 for life patients, the spinal cord injury patients that, you never quite know what their infectious symptoms are. They're not classic. They don't have, feeling below their belly button. And then, you have a patient calling and they tell you they have an infection and you want to take care of those patients. But on the flip side, you look at their culture and it's like, you can only give them IV antibiotics if you want to treat that bacteria, and you have to start making the decisions every single time. Do I want to treat that bacteria? Do I not? And I'm sure that happens with more patients than we realize. To your point, we take care of these patients oftentimes in the tertiary acute setting and then send them back to their referring urologists for their long-term follow-up after they're kind of outside of our surveillance window. And then, I hope we're not doing bad, I hope we're doing right by them, but.
And that's kind of, back to where we started this. It was, going down that rabbit hole that I was like, we really should be better about it. It's not just reconstructive urologists. I started talking to my pediatric colleagues about what they do, and they're kind of in the same boat. It's like, stents, not so much, but a hypospadias repair, everyone gets antibiotics because they're concerned about that breakdown. And I think part of it is I think we need a better understanding of what the bacteria that are always going to be in the urine actually do. Are there some bacteria where if you would just give them 24 hours and sterilize it, it's fine? Or, are there some bacteria that are going to be a bit more resistant and really live in the tissue? And I think we have the technology now to go past just a basic culture. And we really as a field should start thinking about doing that and really understanding the difference between some of the benign and the more pathologic bacteria that live within the urinary system.
Mm-hmm. As far as disease states or disease process go, what's the data look like for some of the common things that we do? So urethroplasty, implants, upper tract reconstruction are the ones that come to mind.
It's surprisingly sparse in terms of showing that there's a benefit to prolonged antibiotic use, even in the implant literature. In urethroplasties, we've seen over the last 15 years, a decrease in terms of number of antibiotics. It was, people being on full treatment doses for 3 weeks or however long it was until the catheter came out. And now more common is just, a couple of days around the catheter pull. In the implant world, I know they've kind of done all sorts of tests and trials about postoperative antibiotic. And as far as I know, not one has concluded that it has definitely led to less infections or less explanting and revisions of either a penile prosthesis or an AUS for doing it. The upper tract literature is a bit more mixed. There really isn't anything there. You're leaving a stent. People are kind of a bit more mixed about that, especially with the nephrostomy tube being in there. Kind of the summary of all of it is that I don't think it helps much. I think if somebody actually did a number needed to treat analysis, we'd be surprised about the number of patients we're putting on antibiotics to prevent maybe one wound infection. It really did cause me to rethink and change my practice and start to really pull back on the antibiotics I'm prescribing. And it's gotten over a little hard recently because I had a rash of Pseudomonas infections afterwards. And I was like, honestly, because we're not doing something, did I need to do something different? But so far, all the patients have done well. So it's kind of, treating the infections as they come instead of trying to get ahead and treating the ones that are never going to be there.
Yeah, absolutely. So you mentioned your practice a little bit. What's your typical protocol for a urethroplasty? I know you touched on it a little bit, but.
Typical protocol for a urethroplasty. So everyone gets a urine culture 2 weeks before. If there are any bacteria there, I will treat it. As long as it speciates out and I get sensitivities from it, I treat that. I only get a proof of cure for MRSA. So otherwise, I just give them a course. It's usually by the time it comes back just through the operating room just because of the timing. So usually end a 14-day course, so it's going to go through the operating room. They get perioperative or periprocedural antibiotics based on that culture, and then that's it. I don't give them anything. If it was somebody who was colonized or had a particularly virulent bacteria, I will give them a dose when I take the catheter out. But yeah, like I said, I really pulled back in terms of antibiotic use in my urethroplasty patients.
Okay. But otherwise, so other than particular virulent bacteria, no catheter pull antibiotics in most folks either. Okay. And you haven't noticed, I know you said you had a rash of a couple.
That's not entirely true. Anyone who gets a rug when it gets pulled gets one dose of fosfomycin because of a rug, but if for whatever reason for timing, it's kind of 4 weeks and I'm just going to pull the catheter right now.
Gotcha. Okay. And then what do you do for, I think you said it has to grow out and speciate, but what do you do for like mixed flora or GU flora?
Nothing.
Okay.
So I don't do anything in treating it for that, but I will go back to previous cultures for what I give them in the operating room.
Gotcha. Okay.
So yeah, I will kind of give them something a little stronger than just cefazolin in the operating room if they have a history of cultures, even if their most recent one was mixed.
Mm-hmm. Okay. And then, and this, this isn't quite our purview, but how does reconstructive urology compare to other subspecialties as far as, like, people giving antibiotics before TURBTs and stone procedures? What's the landscape?
So TURBTs, I'm not sure of. Talking to my kind of oncology colleagues, I know that they're kind of pulling back. All the guys that do prostatectomies are pulling back from 3 days around to just kind of one dose at time of Foley catheter removal. The stone guys, that's a pretty mixed bag. For somebody who has just a regular calcium oxalate stone, I don't think they go crazy, but for those patients who have struvite stones or kind of, history of some sort of urosepsis episode, I think they're a little stricter in terms of treating, getting a test to cure, because they're going up there and with the pressures they're putting in the kidney, there's definitely going to be some translocation of bacteria into the bloodstream for it.
Yeah, those kidney stone patients are the ones that make me worry sometimes about like upper tract. Ureteral strictures, transplant ureteral strictures are the ones that always worry me. They're immunocompromised. They've got a solitary kidney. And for like a majority of the procedure, either it's draining, the kidney's draining the abdomen, or, if you've got your scope, if you put a scope in there during your reconstruction, or you cap a nephrostomy tube, anything like that, I always really worry about those guys. And it's those kidney stone patients, from call and from residency that get really sick and end up in the ICU that make me so worried about some of these upper tract guys.
Yeah, for that, what I started to do for some of my upper tract reconstruction is, without any real evidence, but just thinking, how can I completely decompress the system and still have some antibiotic stewardship? So I have a stent and a Foley in, and they have a Foley in for about a week just to kind of let everything drain out. Think about it for what we do for any sort of abscess, drainage is as good as antibiotics. And I think kind of in the urinary tract, I'm trying to apply similar principles.
Yeah, the Stop It trial in general surgery came out either when I was just beginning residency or maybe just before it. But I don't know if you're familiar with it. It's a general surgery. It was like a New England Journal of Medicine article. It was a general surgery paper that essentially said for intra-abdominal infectious processes, after source control, you only need antibiotics for 4 days, and there was no increase in, reinfections or complications after that. And I always try to remind myself of that, when I'm thinking about antibiotic stewardship for us, if we're talking about like someone getting X-lapped for an intra-abdominal infection or a drain for intra-abdominal infection, if they can get by with just 4 days of antibiotics, then a lot of things, I agree with you, like reliable drainage should do it for us too. What are some common scenarios in recon where you see antibiotic overuse and misuse specifically?
I think really overuse and misuse specifically is definitely the neurogenic bladder patients that I see. And it's not always the urologist's fault, but I think, zooming out and thinking, what can we do to help the patient? I think we need to be better about educating patients for it so that they can advocate for themselves if they're in a nursing facility or just kind of every time they go to the emergency room with like some sort of catheter problem, somebody's going to draw a culture on it and be like, oh, it grew back and we need to put them on something. That patient population kind of drove the development of the clinical trial I'm running as, what can we do to try to sterilize the bladder for patients that have a chronic SP tube. And so kind of using Reconstructive irrigations when they come in for their SP tube changes to see, can we shift what their microbiome is into something that's going to be a little less scary if they go to the emergency room.
Can you, I don't know what kind of data you guys have yet. Tell us a little bit about the trial and kind of where you are in it.
We're still accruing for the pilot phase. I did a couple of test runs with patients that were outside of the trial, so not on protocol as we were trying to figure it out. The one patient that kind of sparked everything was an elderly gentleman with MS who kept having recurrent infectious stones. When I met him, he was on ertapenem a couple times a week with his ID doctor. So we got rid of all the stones, and then I started him on a monthly irrigation where we put 150 cc's into the bladder and kind of clamp his SP tube, and he could hold it for up to 5 minutes, depending on just kind of irritation in the bladder. Sometimes he wouldn't last that long. And we went from multi-drug resistant E. coli to just mixed flora in 4 months.
Wow, that's impressive.
Yeah.
Yeah.
And he kind of got lost to follow up, and, there was a couple months, I think it was 5 months, where he wasn't getting anything. And then, the cycle started again. But, definitely shifted and moved the needle for him. And, so we're kind of seeing with these other patients a definite improvement in their symptoms. And at least if they're still having the irritative symptoms that we know all these patients do, when they go to the emergency room, it's not going to immediately grow back something, and they have a better chance of not getting into that cycle where they're just constantly on antibiotics.
Yeah. And I love the idea of shifting the microbiome as opposed to, I think that sterilizing the urine kind of is the classic goal for us for these procedures. And, maybe it's just shifting the microbiome to less pathogenic bacteria.
And the other patient that I had running through is somebody who had IBS and basically doesn't have enough intestines to take oral antibiotics. And so, every time something grows out, she needs a PICC line or to do kind of infusions at home. So it's just kind of another patient, what can we do to shift it? And she's still growing out. She moved on 4 treatments for her, but it's gone from completely symptomatic to now asymptomatic bacteria. So again, even if we're decreasing the frequency that she's having the infusions that she needs, it is definitely helping with her overall quality of life.
Mm-hmm. One thing that I was curious about kind of thinking about this talk was we've talked about the outdwelling tubes, right? The nephrostomy tubes, the catheters. There was a trial or a retrospective paper, out of Memorial Sloan Kettering, maybe last year, the year before, about stentless urinary diversions, and they didn't see any increase in the rate of ureteroenteric stricture, but they did see a decrease in the rate of urinary tract infections around the time. The theory was that your biofilms build up on the stents, then you pull the stents and it causes pilo. What are your thoughts on it? Or have you switched to stentless urinary diversions?
I haven't switched everything to stentless, but I have for a bunch. So I still will put a stent in for a urethral stricture repair, but any of the kind of diversions I do after a cystectomy, I have switched to stentless. And I haven't really seen any. It's probably been about a year now since I've done it, and I haven't really seen any problems. And I'm sure you have the same thing. It's kind of like how many times in training so the intern would go and pull the stent, and the next thing you know, there's an overhead code because suddenly the patient was uroseptic. There's some translocation, you pulled off a clot, whatever, forgot to give them antibiotics beforehand and did it after, and then suddenly they're septic for it. I think it is a lot easier for patients, especially if you're doing any of the continent diversions, where you don't have to worry about how you're going to get those stents out. And the data kind of is bearing out. I don't really see a downside in terms of outcomes for it.
Yeah, I haven't switched yet. One of my partners here in Patel, he's switched and gives me a lot of flack for not switching, especially because I talk about this paper all the time. Anytime ever, and anyone gets a post stent pull urinary tract infection, but I just my training was always to use stents. You finish an anastomosis over a stent, and at some point I think about it a lot. At some point I'll switch. I had one patient recently where I left ureter was particularly short and not all that healthy looking. So we took a big conduit, we reflected the conduit to the left instead of the ureter to the right. And I couldn't get, there was not a clamp. He was a particularly portly gentleman, and there was not a clamp that could get all the way down to his belly and make the turn for me to be able to grab the stent and pull it back up through. And I ended up doing that one. It was a little ridiculous. I still did my stent on the right as I typically would, but on the left we went stentless, and he did okay. So maybe I have switched against my will a little bit, and maybe I should think about doing it more, but I just haven't quite made the switch yet. Similar to our talk about the antibiotics, it's hard to let go sometimes.
We operate in a world where you never know. You know what happened to the patient, but not what would have happened or could have happened. And, when you have to sit down and talk to that patient or, go back for it, it is very difficult for it. In the realm of kind of another way that people are looking to decrease any sort of antibiotic use in diversions is, I know that they're running a small pilot study, I think out of Mount Sinai, looking at Irricept irrigations after diversions. Again, what can we do to try to sterilize the urine so you don't have that biofilm buildup? And the reason I know about that is that's the bladder irrigation that I'm using. So I do use the chlorhexidine irrigation for the trial that I'm running.
Yeah, and it's an antimicrobial, not an antibiotic. I think he uses, I've seen their presentations. It's something about van der Waals.
Yeah, it's mostly the chlorhexidine gluconate kind of disrupts the ionic bond in the cell walls and so. And because of that, you can also start to disrupt the biofilms on it.
That's been a huge, talking about implant infections. I know that a lot of folks have switched to Irricept for their implant infections, and I think even before that, there's a lot of orthopedic literature on implants and chlorhexidine irrigations of some sort.
Same thing in the plastics literature for breast revisions, kind of washing out that pocket with Irricept instead of antibiotics. It's not going to create any sort of inflammatory reaction that you're worried about with the tissue, while making sure that any bacteria that are there do get eliminated.
Yeah. We're dealing with an infection as opposed to prophylaxing for an infection. But in my Fournier's patients, we put chlorhexidine, we just spike it into chlorhexidine soap. We spike into like a 3-liter bag and then use a low pressure irrigator, not one of the high pressure ones like the ones that can debride, but just a low pressure like agitator. I'll wash all the Fournier in those when they come back for their reconstructions and closures. I've never done it in a comparative way. I think that the disease process is rare enough that I'm not sure that, we talked about doing a trial when I was at the University of Washington, and we can never figure out how quite to get it done. But anecdotally, sure makes the wound look a lot better and smell a little bit better. And we don't have I haven't had a ton of reinfections after secondary closures. So I've been happy with that too.
And then I've also always wanted to do using some sort of irrigation as the wet to dry dressing instead of just saline for it.
Yeah. So that's another thing we talked about as like ways that we might use chlorhexidine irrigation for some sort of Fournier's trial. We talked about it for wet to dry dressing as well. The tough part is, at least when we looked at it, the Irricept bottle, we didn't know what to do with it. You like do a wet to dry and there's no cap. Right. And we didn't know what to do with like all the excess, and it felt, not right to waste it. And, I've always used Dakin's when I feel like I need something, or Mafenide if it's a pseudomonal infection. But pretty much those two things I've never tried Irricept, but maybe it's the next thing.
Yeah. I just kind of the other thing that I was thinking of, for those patients, what can we do to minimize their bacterial load and, hopefully preserve some of the tissue that's there so that when you go back to try to close them, it's a little easier to do. I haven't quite gotten through to some of my emergency general surgery colleagues that, less is more, that you can always go back and cut more tissue, but once it's gone, it's gone.
Yeah. I've had a little bit of success with phrasing it as, in no other situation would you treat cellulitis with excision, or at least I really harp on you only excise the necrotic stuff, and then the cellulitis you try to salvage with antibiotics, and you can reach some folks with that, cellulitis analogy. Others, it's going to take a little bit more time, but we're working on it for sure. But that is one place where I think it's hard, because you want to be an antibiotic steward, but on the flip side, how do you balance antibiotic stewardship versus sparing skin? It can be a little bit of a tougher sell there, where I'm like, just get the cellulitis better.
The way I think about it is just kind of like your capital and your reserve. And so, I think that if we are better antibiotic stewards everywhere, there can be a couple of disease processes or instances where like, you know what, no, we're going to throw everything at this. Maybe it's a little overkill, but in this situation, it's not. And, so if we kind of zoom out and think of like all the times that we aren't using antibiotics where we're trying to decrease that antibiotic resistance, it's so that, in the cases where it definitely can help a patient, get back to their baseline sooner, we can use it for that.
Yeah, I like that. Give me the antibiotics.
That's right. No, you're keeping your powder dry to use it when you need it, as opposed to just kind of using it every day.
Yeah, no, I like that a lot. We have talked about the fact that a lot of us in reconstructive urology are thinking about these things, and the capability is there to do these studies. Why don't you think more antibiotic practice studies in urology, more prospective antibiotic practice studies in urology are being done?
I think it's really hard to unlearn things. There have been several survey studies out of the GERS committee kind of looking at what people do and how close it is to guidelines and recommendations, and across the board, if you want to know what somebody does, look at where they trained, and that's probably what they're still going to do. It's like we talked about at the beginning. We know what the worst case scenario is, and we might not ever see the downside of doing it. But I think it does take a unified effort to try to get those in, to think about it and do it in a safe way where we are thinking about more than, just a culture, and trying to kind of drill down to know what bacteria should we be worried about, what bacteria shouldn't we be worried about. Is there kind of a mix or a threshold to do it? I think, hopefully this could be one of the things that AI and kind of large language models and kind of those model-based studies can help with, where you can kind of know how bacteria or genes are going to change and see that. So, hopefully it won't be putting patients at risk to do it in the near future. It could be something that we can at least simulate first to show people that, it might be safe, and then translate into the real world for like confirmation as opposed to initial testing.
Yeah. And that may be helpful too, the next generation sequencing for every patient is not cheap. Things like Earcept, like it's amazing that they are funding research, but not every trial is going to have, industry funding, and being able to potentially model it out might be a cost-effective way of kind of starting the process, starting the conversation as well.
At least you can get a couple of test cases and see what happens, and use that as your base and kind of go from there. When we first started talking about it, how would we really do a study where we're looking at it, and we're looking at not just cultures, but, how are we changing it with that advanced sequencing? And it's like $100 per culture per patient, and you're doing it multiple times. And kind of that math adds up really quickly for something where you're not exactly sure, what the benefit's going to be.
Yeah, if we're talking about using less antibiotics as opposed to more, it might be tough to get big antibiotics to fund a study.
Yeah.
We've talked a little bit about either urinary microbiome, and kind of, I love the idea of shifting it that you mentioned with your trial. Can you talk a little bit about maybe the history of, we used to consider urine sterile. Do we still? I think I know the answer. And, has research in reconstruction and been done with regards to microbiome?
So, there is a 2015 paper which kind of conclusively proved that urine is not sterile, that there is a healthy microbiome. And I think that's the important word, a healthy microbiome. Everybody knows about their gut biome. And, we learned in medical school that you have more bacteria in you than you have cells, but then we think all bacteria are bad. And to kind of understand that. But outside of knowing that there is a microbiome, there really haven't been many studies that tell us kind of what it is. Is it a balance? If that balance is off, how do you reset it? In the last 2 or 3 years, there have been a couple of publications, not in the urology literature, but in the microbiology literature, that's looking at that and kind of, proposing some trials to move forward for it. And this is another space where computer bioinformatics and modeling can really help. If you know the ratio of the bacteria that are in there and kind of see, where is the tipping point where suddenly you're going to go from, that mixed culture to something that's virulent. So it is definitely kind of a new frontier and coming closer. The closest kind of conclusive data is actually in the gynecology world. They've kind of looked at what is the microbiome in the vaginal canal and how does that impact somebody's UTIs. And so kind of that interplay between the vaginal flora and the urinary microbiome. But there hasn't been anything concrete in the urology literature.
Yeah. And I mean, I'm glad you're out there doing the literature searches too, because, I occasionally will cross over and read some general surgery literature, but I couldn't even tell you what an ID journal, like what their top journal is, it's not one that I think urologists probably cross over to very much.
When I was early in training, someone told me you got to steal like an artist, read what other specialties are doing and see is there a urology paper on it and kind of take that and go with it. I think medicine has become very siloed, and so it's very easy just to think about what we do, and even within subspecialties, so just kind of focus in the recon world, but talking to the oncologists about what they're doing, talking to the stone guys, going outside of it, I think that's really where those ideas and kind of practice changing patterns can really come from. If some other reconstructive guy is telling you, this is what I do and this works. And it's like, okay, that's what you do. That's cool. But if you look and you realize that all of orthopedics is doing this, suddenly it has a little more weight and it doesn't have the bias that we can have when we're just talking about our own field and our own society.
Mm-hmm. Yeah, I've talked about that with a couple different folks in a couple different domains about kind of stealing from other societies, looking at what's common and what's novel and what's old too. ENT already tried all this for trachs and it didn't work. Maybe we shouldn't be, investing our resources in XYZ, initiative. I always find those cross-specialty considerations really fascinating. As far as the future, what do you think it holds?
I think the future is bright, actually, for this. I think the fact that we're talking about this, I did the quick rough PubMed search and just looked at number of publications, and it is a line that's going up. So there is interest in it. I think the future is really going to be being able to tailor a pre, peri, and postoperative antibiotic course to a patient, to kind of understanding where they are, how their other health parameters play into it, instead of just saying, if regardless of what else is going on in the patient, if this comes back, this is what we're going to do. Taking into account are they immunocompromised? Is there a reason where, maybe they don't have as much reserve as another patient? So we should err on the more cautious side in terms of treating things. And then really bacteria do help us. And so, again, moving the conversation away from sterilization and complete cleaning of the GU tract to restoring that balance so that everything is functioning the way that it should be.
Yeah, moving from cleaning to equilibrium again. Yeah, I like the comparison to the gut microbiome. Nowadays people are all about how do we enhance and strengthen their gut microbiome. We probably need to get out of the mindset of eradicating in urology and start thinking about optimizing.
Yeah, I mean, I'm sure you see this too, but I see it in my patients where they had one bacteria all the time. They weren't really symptomatic. And then, they got treated enough and suddenly they have a different bacteria and then now they're very symptomatic. So we've kind of eliminated what was there and allowed a space for this new bacteria to grow and flourish. And, there are numerous patients that I can point to where in an effort to try to help them and treat them, we actually made them worse because, we turned something that was asymptomatic into something that was symptomatic.
Yeah, and just didn't quite understand their symptoms, and we're doing our best, but, maybe took them out of the equilibrium that they've been living in for a long time. As far as the future goes, if a urology department or, subsection, if at Ohio State we decided we wanted to kind of improve our antibiotic protocols, are there models and programs that you've seen work well in urology that we should think about?
Yes. So there was a model at Hanover Medical School from 2022 where it's basically putting in parameters. I know every urologist wants to kind of do things their way, but I think if there are guidelines for it across the department, you can really move the needle on what the bacterial resistance is in your practice pattern. Again, they saw, I think it was just a year after doing this, a 25% reduction in terms of quinolone resistance and for the E. coli in the patients that they were seeing. It was, a little less than 20% reduction of antibiotic use across it. And it was just putting in some basic checkpoints, kind of like instead of reflexively doing something to be proactive and thoughtful about who you're giving antibiotics to and why. Everyone wants a QI project that's a low-hanging fruit, and this is one. And all it really takes is, someone in leadership saying, this is what we're going to do. We went over it, and these are what we're going to put down in terms of who gets antibiotics and when. And then making sure that you follow it. Just because this one study worked and they saw kind of improvement and decrease doesn't mean that, if you do it at Ohio State, that it turned out that, there really wasn't much of a change in terms of the resistance profile. You guys saw an increase in the UTIs. I think as much as we want things to be universal, there is a benefit to kind of doing the same experiment in multiple places to see what are the results for it. And so I think it is having the courage to take that stand for it, and then making sure that it's not just the change, but following it up and seeing, did we meet whatever parameters were set at the beginning. Going back to the start of our conversation, I'm an engineer, and you set your parameters, you set your goals, you do the test, and you see did you meet them or not, and you tweak from there. So kind of without that constant circling and constant improvement, we're really not moving much anywhere. We're just kind of spinning our wheels in place.
Yeah, and it's all for for the betterment of the patient. And there's no better motivation than that for doing something. This has been such a wonderful conversation, and I really appreciate you taking the time to join me on BackTable Urology. I'm kind of already thinking about ways to tweak our practice and things to study. So thank you so much for joining us today.
Okay, it was a pleasure. Thank you for inviting me. And like I said, we can do the same changes in two different places, and to see, what are the differences between Central Ohio and the coast of Connecticut.
Yeah, absolutely. I'm thinking about already the environments and the peoples, and it'll be interesting. Thank you to everyone for listening to this episode of BackTable Urology. It was really great to have you all join, and hopefully we talk more about reconstruction soon.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.